A comparative analysis of healthcare delivery in the United States and Sweden. I will explore key differences between these two systems, including access, cost, quality, health outcomes, and the overall patient experience. This comparison highlights the strengths and challenges of each country's approach to healthcare and identifies opportunities for improving healthcare delivery. This presentation compares healthcare delivery in the United States and Sweden, with particular attention to chronic disease management. I will examine four key areas: access to care, mortality outcomes, hospital readmissions, and avoidable admissions, and patient safety. Overall, the evidence suggests that Sweden provides stronger financial protection and better population level outcomes. However, the United States demonstrates important strengths in the specialized care and selected patient safety processes. This comparison highlights how each system structure influences the quality, accessibility, and outcomes of healthcare delivery. This slide highlights the major structural differences between healthcare delivery in the United States and Sweden. The United States operates through a multi-payer system that includes employer-sponsored insurance, Medicare, Medicaid, CHIP, and Affordable Care Act plans. Although the system supports advanced technology and strong specialized care capacity, access, coverage, and out-of-pocket costs can vary considerably based on employment, income, age, location, and insurance plan. This variation also contributes to administrative complexity and substantial cost sharing for many patients. In contrast, Sweden provides universal health coverage to legal residents through a predominantly tax-funded, decentralized system. Its 21 regions are responsible for delivering most health services, while 290 municipalities oversee much of the social and long-term care. Patient fees are generally limited, and annual cost-sharing caps offer additional financial protection. Overall, the U.S. system emphasizes multiple coverage pathways and specialized services, while Sweden prioritizes universal access, coordinated public responsibility, and affordability. This slide highlights how barriers to healthcare access differ between the United States and Sweden. In the United States, access is often influenced by price and insurance coverage. Approximately 26 million people remain uninsured, while many others are underinsured. High deductibles, co-payments, and network restrictions may cause patients to delay necessary services, which is especially concerning for individuals managing chronic conditions that require consistent treatment and follow-up. In Sweden, universal coverage provides stronger financial protection and promotes greater equity. However, universal coverage does not always guarantee immediate access. Patients may experience longer waiting times, while rural geography and regional differences can affect the availability of services. Overall, the United States primarily struggles with affordability, while Sweden's access challenges are more closely related to capacity and timeliness. This slide highlights the difference in all-cause mortality between the United States and Sweden. Harmonized international data show that the United States continues to experience higher mortality than Sweden. In 2022, the U.S. age-adjusted mortality rate was 798.8 deaths per 100,000 people. However, mortality is influenced by more than just the healthcare system. Income, housing, health behaviors, violence, and public policies also shape population health outcomes. The key takeaway is that although the United States spends considerably more on healthcare, this higher spending does not consistently produce better population level outcomes. This slide highlights how health system design affects chronic disease outcomes and hospital use. Conditions such as heart failure, COPD, and diabetes require consistent prevention, medication access, patient education, monitoring, and timely follow-up. When these supports are fragmented or delayed, patients are more likely to experience complications and return to the hospital. Globally, the pooled 30-day readmission rate for heart failure is approximately 13.2%, although rates vary considerably across countries. Research from the United States also found that outpatient follow-up was associated with a 21% lower adjusted risk of 30-day all-cause readmission, underscoring the importance of continuity of care after discharge. In addition, U.S. diabetes-related hospital admissions in 2023 were more than twice the OECD average. Overall, these findings suggest that accessible primary care, coordinated transitions, and reliable long-term disease management are essential for reducing avoidable hospital use. In this slide, we highlight the complementary patient safety strengths of the United States and Sweden. In the United States, hospital-level safety is closely measured through the reporting systems, quality incentives, and national organizations focused on reducing preventable harm. However, fragmented healthcare delivery and disconnected electronic health record systems make it difficult to monitor patient safety consistently across the country. Despite continued improvement efforts, preventable harm remains a significant concern. Sweden approaches patient safety through national quality registries and public framework that emphasizes systematic long-term improvement. Integrated personal identifiers also support the tracking of medications, treatments, and outcomes across care settings. However, Sweden still experiences challenges related to regional variation and human factors. Overall, the United States demonstrates strength in hospital-based safety measurements and accountability, while Sweden benefits from more coordinated national infrastructure. Both systems offer valuable lessons, but neither has completely eliminated preventable patient harm. This slide takes a closer look at preventable harm within U.S. hospitals. Research found that nearly 1 in 4 reviewed hospital admissions, 23.6%, involved at least one adverse event. Of those events, approximately 22.7% were considered preventable, demonstrating that significant opportunities remain to improve patient safety. Adverse drug events represented the largest category of harm, emphasizing the importance of medication reconciliation, accurate communication, clinical monitoring, and reliable safety systems. These findings also show why healthcare organizations cannot rely only on voluntary incident reports. Chart reviews and automated detection tools can prevent a more complete and accurate picture of patient harm. For nurse leaders, the goal is to use this data to identify system weaknesses, support a culture of safety, and implement evidence-based improvements that prevent future events. This slide outlines several recommendations for improving healthcare in the United States. First, we need continuous affordable coverage that protects patients from excessive out-of-pocket costs. However, expanding coverage alone is not enough. We must also rebuild primary care and strengthen team-based management of chronic conditions such as heart failure, COPD, and diabetes. Another priority is standardizing transitions between care settings. Timely follow-up, accurate medication reconciliation, and teach-back can help patients understand their care plans and reduce preventable complications and readmissions. Simplifying administrative processes and improving interoperability would also allow healthcare professionals to share information more efficiently across settings. Finally, the United States needs stronger national surveillance of patient safety events and greater attention to social factors such as housing, transportation, food access, and income. These improvements should preserve the system's strength in innovation and specialized care while creating a more equitable, coordinated, patient-centered healthcare system. This comparison has several important implications for nursing leadership. Readmissions and adverse events should not be viewed simply as individual patient or staff failures. They often reflect broader systems issues such as gaps in access, communication, staffing, education, and care coordination. Nurse leaders are uniquely positioned to connect what happens at the bedside with larger decisions involving financing, policy, workforce development, and organizational design. Our leadership priorities should include expanding preventive care, strengthening transitions between care settings, standardizing patient and staff education, and improving follow-up. Ultimately, effective nursing leadership means creating systems that support nurses and patients before a crisis occurs, rather than waiting to respond after harm or hospitalization has already happened. To conclude, this comparison shows that both the United States and Sweden have important strengths, but they face different challenges. Sweden provides stronger financial protection and more equitable access to preventive and chronic disease care. The United States offers advanced treatment options and performs well in selected areas of care, but fragmented insurance coverage and delivery systems can create avoidable gaps. It is also important to recognize that universal coverage alone does not guarantee high quality. Health systems must have adequate capacity, continuity of, across settings, reliable health information, and strong culture of patient safety. Ultimately, the strongest path forward would combine Sweden's emphasis on equitable access and financial protection with the United States' strengths in innovative accountability and specialized care. This approach could support better outcomes, safer care, and a more coordinated experience for patients. Thank you for your time. I hope you enjoyed this presentation.